This video will give you some practical tips about red eyes in general practice. There are many causes of red eye. You can think about them according to the different structures as shown here. But for your purpose, try to remember the common ones and the sight-threatening ones. So on the white part of the eye, that is the conjunctiva and sclera, you have acute conjunctivitis, dry eye and blepharitis, subconjunctival hemorrhage, episcleritis, and anterior scleritis. Now notice that episcleritis is quite common, affecting the superficial layer, and that is the episclera, and also is mostly idiopathic. Whereas for anterior scleritis, it involves a deeper layer, the sclera, and classically, it is described as having a deep boring pain of the eye that wakes the patient up in the morning, and the eye might have associated complications such as raised intraocular pressure or even a posterior scleritis. There is a high chance of an associated systemic condition, and you need to make an ophthalmology referral. On the cornea, you have infections of the cornea. That is what we call the keratitis, cornea ulcer, cornea abrasion, foreign body, and also other ocular trauma. Now, if you like, in the inside of the eye, you have acute primary angle closure, uveitis, and also endophthalmitis. Other rarer type of uveitis could also happen in the eye. Now, just a bit of extra information. Dry eye and blepharitis, that is the inflammation of the eyelid, is actually quite common, particularly for patients with rheumatoid arthritis. Severe dry eye is possible. Thyroid eye disease can also lead to red eye, and we will come to that later on in other videos. Apart from acute conjunctivitis, subconjunctival hemorrhage, and episcleritis, other diseases listed here are actually potentially sight-threatening. Dry eye can also be potentially sight-threatening in severe cases. The details of dry eyes are on a separate video. Now I have highlighted the sight-threatening causes in red. So those involving the cornea, anterior chamber, and things that happen inside the eye could be sight-threatening. Notice that subconjunctival hemorrhage is usually not sight-threatening, but if it is severe, involving 360 degree, especially with history of trauma, then you worry about a ruptured eyeball. Anterior scleritis and thyroid eye disease could be sight-threatening. However, they might not look very aggressive sometimes, and so history taking is important. Overall, without the ophthalmic instrument, it is challenging to judge how urgent your referral should be. Don't worry too much about the details of the causes yet. You will get back to this in the future ophthalmology clerkship. For practical purpose, even if you don't remember the differential diagnoses, all you need to do is to know when to make the referral. So the essential thing to remember is the alarming signs and symptoms. Consider referral if the patient has significant visual loss, severe pain, photophobia, proptosis, if you see a mass or other specific signs, and I will get back to these signs in a minute. When there's a significant visual loss, obviously it's more alarming if the visual loss is acute, then it could be the cornea or pathology involving the inside of the eye. Severe pain could be related to acute elevated intraocular pressure, inflammation, as if uveitis, and infection. Photophobia is actually quite a specific sign and usually indicates a cornea or iris pathology. Proptosis, or if you see any obvious mass, then it's thyroid eye disease or other orbital pathology. Even without a sort of high-end ophthalmic instrument such as the slit lamp, you could still spot some of the alarming signs. These signs include obvious pathology on the cornea, such as a cloudy cornea, which may indicate corneal edema, hypopyon, which is a collection of pus in the anterior chamber, indicating an ongoing severe intraocular inflammation such as endophthalmitis, a central corneal lesion, which could be a corneal ulcer. A minor and spontaneous subconjunctival hemorrhage is probably alright, but if a patient has a 360-degree subconjunctival hemorrhage, particularly has a history of trauma, then be very careful about ruptured eyeball. If the eye is tested RAPD positive, that is relative afferent papillary defect, we will get back to this in the future, color blindness, red desaturation, then you worry about optic nerve involvement. For acute angle closure, it's usually presented with a sudden onset of visual loss, red eye pain, and so painful that the patient could actually feel sick, and you might be able to see a cloudy cornea and mid-dilated pupil. Again, we'll get back to the details when we get to the clerkship. Talking about some of the less worrying red eyes, viral and allergic conjunctivitis are uncomfortable and the onset are acute, which could be alarming. However, if the patient doesn't have visual loss or photophobia, it is likely to be okay. Subconjunctival hemorrhage, as I keep saying, it is safe though usually look alarming, but be concerned if you worry about ruptured eyeball. Episcleritis comes spontaneously and occasionally could be related to systemic condition. However, it is usually idiopathic, a standalone problem, and is self-limiting. And usually, symptomatic relief with lubricating eye drops will do the trick. Ophthalmologists may prescribe a short course of mild topical steroid. Now, dry eyes and blepharitis can lead to red eye, and we will talk about that in another videos on excessive tearing. Okay, let's talk about viral conjunctivitis. Patient could present with unilateral red eye and could be itchy. It then affects the other eye a couple of days afterward because of cross-infection. There might also be foreign body sensation, having some watery discharge, so much so that some patients will tell you that it glues up their eye when they wake up. If there's a photophobia and blur vision, it could imply corneal involvement and you need to refer them to ophthalmologists. There could also be other associated symptoms, such as upper respiratory tract infection. There could also be a traceable contact history, such as having contact with people with red eye and also swam in a swimming pool a few days beforehand. If it persists for weeks and shows no improvement, refer them to the ophthalmologist. Clinical signs include watery discharge, conjunctival injection, and you might detect a palpable tender periocular or submandibular lymph node. In severe cases, you might be able to see pseudomembrane formation in the phoenix as shown here. The disease is self-limiting. There are measures for symptomatic relief such as cold compression and lubricating eye drops. Remember 3 important differential diagnoses, and they are allergic conjunctivitis, bacterial conjunctivitis, and uveitis. Refer them to us if necessary. Now, for patients with bacterial conjunctivitis, we will do eye swab for culture and sensitivity and also give topical antibiotics. For allergic conjunctivitis, advise the patient to avoid allergens. They could also do cold compression to relieve the symptoms, and we will also prescribe topical or systemic antihistamine with or without short course of topical steroid during the flare-ups. Allergic conjunctivitis is a type 1 hypersensitivity reaction to airborne allergens. It could be seasonal or perennial, so basically just like allergic rhinitis, hence the same content when you're doing your history taking. In fact, the 2 allergies might come together. It is very common among children. The patient might have a history of atopy. It's more obvious if the patients feel itchy or have a watery discharge. Now for children, they might rub their eyes, or the parents may tell you that they blink a lot. Now, what happens is, parents tend to tell their kids not to rub their eyes, but they feel itchy, so they try to relieve the itch by forcefully blinking their eyes. That's why they blink a lot. It is actually quite difficult to differentiate the allergic cause from the viral cause. So basically, for allergy, the eyes are less red, if you like, the symptoms are less florid, the discharge are more watery, and the swelling is more significant. This is a classic example of acute allergic conjunctivitis. As you can see, the eyelids swell up, there are obvious chemosis, so much so that the conjunctiva look like they are protruding out. It is quite itchy and the vision is not affected. It is rather alarming, and you can imagine how worried the parents could be. For allergic conjunctivitis, you might see some injection, but the injection is quite diffuse. But the treatment is mainly about avoiding the allergens. Conservative approaches such as cold compression and lubricating eye drops will be fine for mild cases. You could also add mast cell stabilizer or topical antihistamine. Topical steroid is very effective. We usually give a short course of mild type of steroid. However, it's probably better to leave that to the ophthalmologist. Steroid could lead to complications such as steroid-induced elevated intraocular pressure, cataract, and flare-up of herpes simplex keratitis. So you need some monitoring. Vernal and atopic keratoconjunctivitis are the more severe types of allergic conjunctivitis, and they are beyond the scope of this video. Just a reminder about the other sight-threatening red eyes. They are scleritis, thyroid eye disease, corneal pathology, inflammations or infections, but basically uveitis and endophthalmitis and acute angle closure. Anterior scleritis could lead to complications that affect the vision, although this is not very common. Classically, it is a deep boring pain that wakes the patient up in the morning. The scleritis could sometimes be posterior, and the red eye may not be that obvious. Thyroid eye disease, I'm sure you're more familiar with. You can imagine that an extreme accumulation of soft tissue and swelling in the orbits could lead to complications. Now, compressing on the optic nerve could lead to compressive optic neuropathy. If the eyeball is pushed out too much, then the eyelid cannot close the eye properly, and that leads to exposure keratopathy. It can also compress on the eye, causing elevated intraocular pressure and so glaucoma. What you can do is to ask the patient to close the eyelid and see if there is any exposure. Now, you can also test the pupil for RAPT if you're concerned about optic nerve involvement. Corneal involvement can obviously lead to visual loss, especially the central part of the cornea. From the history, you may be able to see whether red eye is related to contact lens wearing, trauma, or any foreign body. Photophobia, pain, and blur vision may suggest corneal involvement. Anterior uveitis is more common than other type of uveitis. The patient may feel that the vision is blurry in a sort of foggy way, best elicited if the better eye is covered up. There may be photophobia because when the light comes, the pupil constricts. Now the inflamed iris is moving, and that causes pain or discomfort. Patient may see floaters and flashes of light, although that usually happens to posterior uveitis. From the outlook, the eye doesn't look very injected. The injection tends to happen along the limbus, and that's what we call the ciliary injection. Under slit lamp examination, you will be able to see some cells floating about in the anterior chamber, and that explains why the vision becomes foggy. Endophthalmitis could be caused by endogenous or exogenous source. For exogenous, there could be a prior injury or infection of the eye, such as corneal ulcer. For endogenous, we need to do a septic workup. Now, usually the signs and symptoms are very florid. I don't think you'll miss out if you check out the eye properly. This photo is not endophthalmitis. I'm putting it here just to show you how it may look like. The photo is actually a young patient who has history of ankylosing spondylitis with anterior uveitis. As you can see, the eye is actually not that red. I just want to show you how hypopyon looks like. For acute primary angle closure, the patient classically presents with unilateral painful red eye with blur vision and seeing halo. It's so painful that the patient may have nausea and vomiting. This group of symptoms implied an acute raised intraocular pressure, so that could happen to any causes of acute elevation of intraocular pressure, including uveitis, lens-related, or neovascular glaucoma. The eye is obviously red with a cloudy cornea because of raised intraocular pressure. That explains the blur vision and seeing halo. For acute angle closure, the pupil is mid-dilated because that is the position when aqueous flow is obstructed. They might have a history of cough mixture intake or had eye examination that requires dilating the pupil. The cough mixture and anti-cold medication contains anticholinergic and epinephrine ingredients. Both could dilate the pupil and can trigger an acute angle closure. In the clinic, you could feel the eye pressure by using the two index fingers. Just like that in the photo, you can compare the two sides and you will feel that the affected side is harder. This table compares episcleritis and scleritis. For the phenylephrine eye drops, it's better to leave that to ophthalmologists. For your reference, we have also summarized some of the points we discussed about allergic, viral, and bacterial conjunctivitis. If you look at the pharynx region, you can see that by just pushing the lower lid downward, then you may be able to see papules for allergic conjunctivitis, and it appears more watery, ecchymotic, if you like. Whereas for viral conjunctivitis, you may see follicles and is more injected. This could be difficult with our slit lamp, so mainly rely on history taking. Don't worry too much about forgetting the details at the moment. For practical purpose, I just need you to remember when to refer the patients to ophthalmologists. The warning signs, including significant visual loss, severe pain, photophobia, and when you see obvious signs such as proptosis. Remember the sight-threatening red eyes. Again, refer to ophthalmologists if you suspect them. And for steroid eye drops, better leave that to the ophthalmologist. These are the references. And thank you. Bye bye.